You can Spanish?
No, not yet.
Para mí es un honor presentar al doctor Norbert Bornfeld, profesor que fue mío desde el año 89 al 90 cuando estuve haciendo el fellow en Essen. Es un gran honor poderlo presentar. Desde ese momento lo conocí y era el Oberarzt, que se llama ya como el profesor ahí ya más adelantado de la parte de retina clínica. El doctor Norbert Bornfeld hizo el estudio de medicina en Bochum y Essen, hizo su promoción como oftalmólogo en la habilitación y fue realizada en Essen. Desde el inicio de su formación se dedicó a la investigación de tumores oculares, siendo autor de innumerables publicaciones a nivel internacional, autor de libros, como también conferencista reconocido a nivel internacional. Ha estado ocupado como Oberarzt en la Augenklinik de la Universitätsklinikum de Essen. Fue profesor también en la Universitätsklinikum Benjamin Franklin de la Freien Universität Berlin. Fue director de la Hinterabschnitt, o sea, del polo posterior, de enfermedades del polo posterior en el Centro de Oftalmología de la Universidad Clínica de Essen y ha sido director hasta el 2018. En este momento también está siendo parte del Departamento de Retina en el Centro de Oftalmología en Düsseldorf. También van a tomar parte la doctora María Elena González, oftalmóloga, oncología ocular, del grupo de Retinoblastoma, Hospital San Vicente, Fundación de Medellín. Y nos va a hablar también sobre el tema de Retinoblastoma, What's Happening in the Developing World. Y también va a estar la doctora María Lía Gaviria, oftalmóloga pediatra, grupo de Retinoblastoma, Hospital de San Vicente de Paul, en Medellín, en compañía del doctor Juan David Bravo, altamente conocido por todos ustedes, que es retinólogo y fue expresidente de ACOREF. El Dr. Bornfeld nos va a hablar del New Treatment Approaches in the Management of Retinoblastoma. Norbert, please, all the audiences are hearing you.
Yeah, thank you. Yeah, Berto, dear colleagues, it's a pleasure for me. It's my first midnight talk ever to give, but it's my pleasure to do so due to the time gap between Germany and Colombia. And I would like to give you some details or some ideas on new treatment approaches in the management of retinoblastoma. And I will focus the first part of my talk on proton treatment of retinoblastoma, and the second part on the combination of brachytherapy and new aspects in local chemotherapy of retinoblastoma. And I would like to start with the first topic. This is proton beam radiation of retinoblastoma. External beam radiation had been the standard treatment for retinoblastoma for decades. And it's a very effective treatment. This is how it is done, has been done, it's not done anymore. But linear accelerator was used with 48 gray or 50 gray in 200 centigrade fractions. And that was a very effective treatment, as shown in this fundus image on your right. And it shows you a large retinoblastoma close to the optic disc and the same tumor after external beam radiation with complete regression in what is called the cottage cheese regression pattern, with complete regression and calcification of the tumor remnants. So that is very effective. Why had that been abandoned? It has been abandoned because of the high proportion of secondary malignant tumors, particularly arising in the radiation field if a linear accelerator is used. In a standard technique treatment, a linear accelerator just covers the whole midface, and retinoblastoma patients with heritable retinoblastoma with a germline mutation have a very high risk of developing secondary malignant tumors in the radiation field. Is shown here in a patient of our clinic who was treated as a child in our clinic with external beam radiation, presented then as a young adult. And what you see is a soft tissue sarcoma with clever impression and multiple metastases. The patient, the liver, pancreas, and the skeleton. And the MRT on the right shows you that the tumor is impressing the ball of the eye. It's not an intraocular tumor, but it's the impression of a large soft tissue sarcoma in the orbit pressing on the eye. That, of course, is a very, very, very unfortunate time course. And we now from our clinic, another clinic, have published that as well, that if you look at these patients in a long time follow-up, and it needs decades to find out, that these patients who had external beam radiation, in particular patients who had a combination of chemotherapy and external beam radiation, that is a red graph, have a very high risk of getting secondary tumors. So the mortality of treatment complications related to external beam radiation is higher than the mortality of the primary tumor. And of course, this is not acceptable. So in our centers worldwide, external beam radiation has been stopped. But you will see, and as we did, and all the centers will see patients who have a very, very complicated situation. And that is a case illustrating the dilemma you may find in if you just abandon external beam radiation. That is an unlucky young patient who has just one eye, the other eye had been removed due to bilateral retinoblastoma. And what you see is a recurrence after systemic and intravitreal chemotherapy and brachytherapy, and the recurrence in the temporal superior periphery of that eye. And that again has been treated with additional brachytherapy and additional intra-arterial chemotherapy. And luckily, at that stage of the disease, there was a regression of the tumor, as shown on the funnel slide on your left. But then the patient presented 2 months later with a massive recurrence and which was seeding of the tumor in the anterior chamber, as seen on your right, with a pseudo-hypopyon and massive seeding of tumor cells in the arterial segment. So that cannot be treated with intra-arterial chemotherapy that has been done. Just every option has been used in that patient. And the only option to keep that last eye probably would be radiation. But external beam radiation is not, as we have seen, a good option because of the high mortality after decades after treatment. So we were just very busy in the last year to look whether proton beam radiation may be an alternative. And what is the difference between proton radiation treatment and the linear accelerator with photons? The main advantage of protons is a minimized risk for collateral radiation of the adjacent normal tissues. There's a very small penumbra, it's less than a millimeter. There's no exit dose due to the Bragg peak, so nothing is radiated beyond the orbital wall. And you can just create, and I will show you later in my talk, a radiation field where the bony orbit largely is outside the irradiation field. So the bony orbit is kept outside the field, and the risk of getting secondary radiation-induced tumor in the bone or in any other tissue definitely is diminished. And fractionation and reproducible settings can be used using a gantry with a patient couch. And I will show you the setup in Essen as we use it now. It's not a new treatment, and in particular the Boston group has been very busy. Dr. Muka and others have published some years ago on a large series of 49 patients and have found very favorable results, as shown on the right of that slides, and it's from the publication in 2014, and that encouraged us to just in essence to find out whether proton treatment might be a valuable option in the treatment of complicated retinoblastoma. This is a setup in Essen. This is a cyclotron which is dedicated to medical treatment. It's not from the physics or physical research. It's just a dedicated cyclotron from IBA, from Belgium, for the treatment, for medical purposes, for medical use. And the setup is a gantry on the right, and that is used to treat our children. These children are fixed with a custom-made fixation for each patient. And of course, it is done in general anesthesia, as shown on these slides. The eye is marked with 2 Tantal clips. 2 are just needed to find out the position of the eye in relation to the proton beam. And target dose of 50 grays is used in 20 fractions, which is very similar to that what is used in a conventional photon treatment. This is the radiation planning, and what we do now, and I will show you in some cases why we do it in this way. What we do now is using an anterior field, where the anterior field edge is placed posterior to the lens. And what you see on that radiation planning is that the bony orbit, not completely, but largely is outside the radiation field, and just the temporal side of the orbital orbital bone is exposed, but that can be very easily followed, in our opinion, during the life to the months after radiation treatment. So the temporal side of the orbital bone is exposed to radiation, but nothing else. No other parts of the bone are exposed, and it definitely is an advantage to any other treatment. That is the same unlucky patient you just saw some minutes ago with a massive recurrence after just using all the options we have now in the treatment of retinoblastoma, with a massive seeding of tumor cells in the anterior segment. And that is the same patient the months after proton treatment. And that is a complete regression of the whole tumor. And what we have learned in the last years is that radiation exposure of the anterior segment to protons is not a very good option. That has to be done in this patient, so the anterior segment had to be placed into the radiation proton beam, so it has been included in the target volume, and it ended up with complications of the cornea. Luckily, that could be compensated with a corneal transplant, and that is still a visible eye. The alternative in that patient would have been to enucleate the eye, and that eye could be saved, but of course, that ends up with massive anterior segment complications when the anterior segment is included in the target field. So that should be omitted whenever possible. The results are much more favorable if the tumor is confined to the posterior segment. That is another patient with a recurrence after systemic chemotherapy, intraocular chemotherapy, intraarterial chemotherapy, and no further option to perform intraarterial because of occlusion of the artery, and that couldn't be done, so intraarterial was not an option. And one of the options would have been to do laser treatment or put a plug on it, but that probably would have ended up with radiation neuropathy and massive vision loss, as the recurrence of the tumor is close to the optic disc. And that patient has been treated with protons, and these are the most recent patients we have treated. What we have learned is to confine the field and to define a much smaller field compared to the patient you just have seen. And so this is a very small field, and just a fraction of the temporal orbital bone is included and no other bone. And that is the lateral view of the same field, and shows you that we have a very small field just confined to the recurrence of the tumor. And that is the same patient, and that is the patient 2 months after proton treatment with complete resolution of the tumor, and that is a stable finding now for more than 1.5 years in that patient. So that is a very favorable outcome. And there's another patient with a recurrence after intraarterial chemotherapy. This patient again has no further treatment option, which is frequently occurring using intraarterial, because we get vascular complication. We just recently published on that we get vascular occlusions, and some of these patients cannot be treated with further sessions for intraarterial chemotherapy, and that patient then has been treated. Would have been a plug placed on that tumor, but that would have ended up with a large scar at the posterior pole, and that patient was treated with proton radiation 6 months after treatment. There's complete resolution of the tumor, and again, a very favorable outcome in that patient. So far, we have treated 15 eyes from 13 patients with protons. Most of these eyes were just only eyes. 2 had bilateral radiations, and 13 eyes had recurrence after intraarterial chemotherapy. So most of the patients were patients who had failures or recurrences after intraarterial chemotherapy. 2 eyes had a diffuse infiltrating anterior retinoblastoma. You have seen just one of these 2 patients in the slides. Mean age was 35 months, and the mean follow-up for this presentation was 6 months, ranging up to 32 months. So we have in some patients a very long follow-up. The international classification or stages, according to the international classification, retinoblastoma were mixed from A to E, so just every stage of retinoblastoma was included, and 3 of these eyes were unclassified because the prior treatment before we saw the patients has been done elsewhere. Secondary enucleation was performed in 5 eyes, and none of the patients who had been unclassified and pre-treated could be preserved. And all the remaining eyes, 2 of these 5, the other 2 patients had stages D and E, so very advanced stages, and the indications for secondary enucleations in these patients were recurrences, lost visibility due to complications in the anterior segment, a massive exudative retinal attachment which occurred in 1 patient. And in one of these 5 patients, the tumor was completely destroyed, and there was persistent tumor tissue in the other 4 patients. But luckily, all the other patients who had stages A and B of retinoblastoma could be preserved, and none of these patients had anterior segment complications, no dry eye, no vascular, no corneal complications. So if the tumor is confined to the posterior segment and does not reach the anterior segment, the results are very favorable. I'd like to address the second topic of my talk, which is the combination of intravitreal chemotherapy in retinoblastoma with brachytherapy. And this is showing the problem. These are different patterns of vitreous seeding of retinoblastoma with dust, cloud spheres, and partially calcified. And we know from many centers, and Adams in New York has published that recently, that vitreous seeding is one of the most important risk factors for final failure of treatment of retinoblastoma. And vitreous seeding is the main reason for nucleation after intravitreal chemotherapy, and is a real complication and very complicated to treat. Systemic chemotherapy does not reach these intravitreal seeds, and intravitreal chemotherapy is a real big step forward in the treatment of retinoblastoma. Intravitreal chemotherapy is not a new idea. The first injections were done in the early 90s in Japan by Dr. Kaneko, who is a pioneer in that field, and it just wasn't taken seriously. So there was an intensive discussion among the retinoblastoma centers for 20 years, and it wasn't accepted because of the risk of extraocular tumor seeding. And so Dr. Kaneko was for 2 decades the only ophthalmologist worldwide to do that type of treatment. And so he's a real pioneer, and he was very, very active in order to make that treatment available to us. And he should be more honored and more remembered as it is done now, because he is a real pioneer in that type of treatment. There was a relaunch in 7 or 8 years ago worldwide. As all the centers had published that external beam radiation, just shown to you, had to be eliminated because of the risk of secondary malignant tumors, and some more options had to be used in the armamentarium in the treatment for retinoblastoma. So the relaunch was done, and that was pioneered by the Swiss group and other groups worldwide, and they adopted Dr. Kaneko's idea. 2 different drugs are used worldwide. So one drug is melphalan, which is most commonly used, which is the most commonly used medications for intravitreal chemotherapy and retinoblastoma. It's a well-known alkylating anti-cancer agent, and which blocks, as most of all these drugs do, tumor growth by inhibiting DNA biophantesis. And the other drug used is topotecan, which is a special inhibitor producing a lethal damage in DNA replication of cells, and that is not so frequently used. Melphalan by far is the most widely used drug, and topotecan has been proven to be efficient in some periodic tumors, but it's definitely less frequently. There is a technique probably which we use and most of the centers use worldwide. Our main indication is stage COD, retinoblastoma international classification. What we use, a bit different to other centers, is to use punctum plaques and to occlude the lacrimal duct. We use preoperative ultrasound to be sure that the injection is not done in a tumor site or where tumor is growing. A paracentesis is used to lower the intraocular pressure, and histology of the aspirate is done to be sure that there are not tumor cells. And we have done now hundreds of intravitreal chemotherapy and have just found in none of the aspirations any tumor cells. So it's a very, very safe approach. Then the intravitreal injection of 25 microgram melphalan is done in 2 mm distance from the limbus, and triple freeze-thaw coagulation at the injection site is done to be safe. And so far, we haven't seen any extraocular extension. If I'm right now, just recent literature has shown some cases worldwide, definitely less than 10 or so. So it's a very safe technique, and there is no extraocular extension of that technique. It's a very effective technique. It's one of our best options we now have in the armamentarium of treating retinoblastoma. This is a case of a 21-month-old male patient, the only right eye, and that patient had systemic chemotherapy, brachytherapy, 2 plugs, cryotherapy, and then he had a recurrence, a very small recurrence at the inferior temporal arcade, and that is a real mess. And that patient was treated with intravitreal injection, and that is a follow-up after 3 intravitreal injections, and shows you the efficacy of that method. And that cannot be reached with any other method. So intravitreal injection is one of our main options in the armamentarium of treating retinoblastoma. Another option is ruthenium brachytherapy, and ruthenium brachytherapy is very effective in treating small solid tumors. And this is recurrence after repeated photocoagulation of a small retinoblastoma, and that is treated with a small retinoblastoma plaque and complete regression of the tumor. So that is effective, no radiation to the orbital wall and no risk of secondary tumors. But some years ago in 2006, our group and other groups later have published what are the main risk factors of final failure in brachytherapy. And one of the main risk factors in final failure is vitreous seeding. So vitreous seeding, as just shown you previously in this talk, is one of the most important risk factors for final failure, and that is true for brachytherapy as well. Vitreous seeding has a risk ratio of more than 2 for final failure. And so it has been looked at as a contraindication for performing brachytherapy because of the risk of recurrence. And what we have done is to look at the combination treatment of brachytherapy and intravitreal chemotherapy to improve the prognosis in cases where small tumors have limited vitreous seeding, which may occur frequently. And we have looked for our patients who had intravitreal chemotherapy before or in combination with ruthenium brachytherapy. All these patients has been treated according to our standard protocol with 25 micrograms melphalan in all these eyes. 2 of these eyes in the series, I will show you the data later in my talk, have been treated with additional 20 micrograms of topotecan intravitreally, and the mean dose to the tumor base was somewhere around 560 gray, and the mean dose to the tumor apex in our series is about 88 gray, which is our standard setup for treating retinoblastomas. I'd like to show you some of these cases. That is a very unfavorable case where a solitary tumor has resulted in diffuse vitreous seeding with dense vitreous seeding of the tumor. The primary tumor has been treated successfully with local radiation, and 9 cycles of intravitreal chemotherapy have been performed, and that's led to a complete resolution of the intravitreal seeding of the tumor and complete regression of the primary tumor, leading or the source, which was the source for the vitreous seeding, and complete regression of the tumor. And that result could have been reached with any other method. It could have been reached not with chemotherapy, not with intraarticular chemotherapy. So the combination of intravitreal chemotherapy and brachytherapy was effective in this case. And there's another patient with this tumor and was causing vitreous seeding, as shown on the right of this slide. There is a patient after local radiation of the tumor and subsequent intravitreal injection. Had destroyed completely the vitreous seeding. What you see on the right in the upper part of that fundus image is somewhat what we call a salt and pepper reaction of the peripheral fundus. So it shows you that using these concentrations of melphalan is close to a very toxic dose. And in most of these patients, you will find that salt and pepper degeneration of the peripheral retina, which has no effect on the function, but it shows you that what we use intravitreally is very close to the toxic dose to the retina. So one has to be very carefully inject that drug, and to be sure that it's not injected close to the fovea, of course. Another case of a large tumor with vitreous seeding on the apex of the tumor, and that tumor has been treated with brachytherapy and 3 cycles of intravitreal chemotherapy with complete regression of the tumor and complete resolution of the vitreous seeding. So again, it's a very favorable outcome. So far, we have looked at 18 eyes from 18 patients, where the first combination of intravitreal chemotherapy and brachytherapy was the first line option in 7 of these patients. Different retinoblastoma stages according to the international classifications from B to E. And the median follow-up on these patients is a bit more than a year. And that's the median age of brachytherapy, and the mean number of intravitreal chemotherapies after brachytherapy, which is about 6, which is our normal number of cycles we need in intravitreal therapy, therapy of retinoblastoma. And in more than 70% of these eyes, which have an unfavorable prognosis, the eye could be saved, which is a very favorable outcome. We're just looking our recent results and just going to publish these results and repeat it Of course, some patients more than shown on these slides, but we feel that the combination of brachytherapy and chemotherapy is very effective. So in summary, proton radiation treatment is a very valuable option for blastoma stages A and B. With otherwise exhausted treatment options. It's definitely not the first line option, but in those patients who have a recurrence at stage A or B at the posterior pole, proton radiation is able to preserve vision and has definitely no complications, radiation-related complications in the anterior segment, and hopefully no radiation-induced complications in terms of secondary malignant tumors of the orbit. And what we feel additionally is that the combination of adjuvant intravitreal chemotherapy with brachytherapy may improve the results in retinoblastoma eyes where there are small tumors which are accessible for brachytherapy but have vitreous seedings and would have had otherwise an unfavorable outcome, but the prognosis of these patients can be improved by combining intravitreal chemotherapy with brachytherapy. That's it. Thank you for listening.
Thank you, Norbert, for your excellent presentation. And we move on with the next theme that, one second, please. The next theme is, hablará María Elena González about the retinoblastoma, what's happening in the developing world. And later we are going to the audience to do the questions to Dr. Bonfeld and to the moderators. Okay. María Elena.
Sí, Alberto.
Sigue.
Estamos abriendo la pantalla. Okay, are you seeing the slides?
Yes,
yeah,
perfect.
We do. Perfect.
Okay, thank you, Dr. Norbert. It was wonderful results. Great for you that you have proton beam and plaque radiation therapy. We don't have treatment like that in Colombia and in many countries in Latin America. So I will present another point of view of retinoblastoma. And the topic is what's happening in the developing world. Our condition in the developing world is different. If you see the map, the developing world includes medium and low income countries. Many countries in the world presenting these characteristics, as you see in Latin America and in Africa and Asia. Many countries belongs to this category of developing world. So, there are many differences between developed and developing world. These are the main things. Diagnosis, if you see, early diagnosis is very common in developed world, and this diagnosis is normally late in our countries. Financial support is different too. Symptoms, leukocoria is the main symptom in the developed world, and proptosis is very rare in developed world, but it's common in our countries or in developing world. Treatment abandonment is one of the other big problems. In our countries, the abandonment of treatment could be up 40% of our cases. The goals of treatment are different too. In the developed world, eye and vision are the main goals, and for our countries, life is the most important goal of the treatment. Eye preservation is important too, and patient survival, as you see in the table, is very different too. So what's happened with the possibilities in our country? In countries like ours, in some of our countries, we have this alternative, intraarterial chemotherapy and intravitreal chemotherapy. We don't have plaque and we don't have proton beam radiation. Have you seen the slides now?
Yep.
Okay. So I will present a brief report of our 8 years experience in a single referral institution in Colombia, San Vicente Hospital in Medellin. We included 100 eyes, 75 patients, 513 injections directly into the ophthalmic artery. The catheterization success was 99%.
That's a good.
Yeah. The majority of our patients present characteristics of bad prognosis disease. I mean bilateral disease, advanced disease, group D and B, that is related to late diagnosis that is common in our countries, and secondary treatment is in the majority of our group. We use the combination of intraarterial chemotherapy plus intravitreal chemotherapy in 40% of our cases. Our median follow-up was more than 3 years, 36 months, and the overall glow salvage in this study was 75%. As you see in this table, this is the international classification of retinoblastoma from group A to E. The majority of patients in the first 3 groups, A, B, and C, are very good, but see what happened with group D and E. In these groups, D and E, bad prognosis group, we got 61% of glow salvage. Remember, our number were 100 eyes. So what happened with the complication? Intraarterial chemotherapy has systemic and local complication. As you see in this slide, systemic complication presents in 18 of our eyes. The most important complication were contrast media allergy and neutropenia. One patient presented stroke and hemiparesis. It was related to the learning curve. One of our patients, his parents refused enucleation, died for metastasis. So what about the local complications? The local complication related to intraocular and periocular complications, eyelid and frontal erythema, and chorioretinal atrophy were the most important complication. Loss of eyelashes, palpebral edema are common too, but generally they are mild and transient. Retinal hemorrhage, retinal detachment, and vitreous hemorrhage were less common, as you see in this picture. In conclusion, intraarterial chemotherapy and intravitreal chemotherapy are safe and efficient procedures. They allow to improve the eye salvage rate, especially in developing countries where late diagnosis and advanced disease have been the main cause of enucleation. I would like to share with you some useful strategies that allowed us to improve our results. First of all, simultaneous multidisciplinary approach. If you see this picture, the ophthalmology team and the neuroradiology team, we share the same operating room. So which are the advantages of this strategy? One is decisions are discussed among the team. Second, fewer anesthetic procedures because there are fewer anesthetics. Lower costs and optimization of the resources. Other strategies that are useful for us are teamwork. It's important to mention here the role of social worker. That is very important in countries like ours. The family commitment is reliable too, and monetary donation is very important to have a good fundus to these patients. And finally, what are the goals in developing world? Decrease mortality is our first goal, and the number of enucleation through early diagnosis and timely referrals. Second, implement reference centers, promote scientific cooperation with other countries, and stimulate early detection campaigns. Thank you very much for your attention.
Thank you very much, Maria Elena, for your excellent presentation and very interesting. That's from Colombia. That's very important. And Dr. Bornfeld, heard your statistics and your presentation. I would like to know what questions do the audience have for the two presentations. And Juan David Bravo please, if you have any question, you can do in this moment.
I would like to have 2 questions, if I may, to the last presentation. And but puzzled by 2 figures. Our experience is of getting we get technical problems in terms of getting a catheter in the right artery, or getting it just from a technical point be done in a much more high frequency. We do not have a success rate of more than 90%. It's definitely less. In roughly about a third or a quarter of the, not a third, or a quarter of the patients, it just from our experience here, technically not feasible to perform the intra-arterial. And what we feel, and we just have published it in the British Journal, is after repeated intra-arterial chemotherapy, there are some changes in the vessels. And we have just reported the histological findings of these eyes, which had to be removed after intra-arterial. And what we found is an extensive thrombosis, damage to the vesicle walls, to the endothelium, and vascular occlusion in eyes which have been treated with anterior chemotherapy. And we have seen a lot of patients who got extensive coloretinal atrophy. That has been published by others, in particular by the Lausanne group, that patients may have extensive coloretinal atrophy after intra-arterial chemotherapy. Is that your experience as well?
Yes, we have the same experience here. The toxicity from intra-arterial chemotherapy, and especially when we use more than one drug. And as you know, we saw very bad cases in the majority of our patients, and we have to use more than melphalan. In some cases, we have to use 1, 2, or even 3 drugs: melphalan, topotecan, and carboplatin. And this toxicity is very common. I think if we have the opportunity to use, for example, brachytherapy in some cases, it would be better.
What puzzled me, you have a very high rate in group E eyes to salvage these eyes. Is that due to the fact that you're using a combination of 3 drugs?
Yes.
So that you're more effective, but probably is that, as you said, probably there's a higher risk of getting toxic side effects, isn't that?
Yes, Dr. Norberg, yes, it could be possible. Yeah. Because if you see the median catheterization, where 5 per eye, is higher than the publication, the majority of publications where there are 3. And in our study, in our report, there were 5 per eyes. And the other explanation for the successful in group E or D could be more drugs. And in some cases, we combine intra-arterial plus intravitreal.
Yeah.
So I think it could increase the successful, but increase the toxicity too. But as you know, in our countries, one of our goals is at least to preserve the eye. Sure. We try to get good visual acuity results, but it's not our main goal in this moment.
Sure, yeah. Sure, yeah, impressive. You have excellent neuroradiologist. More than 90% technical field is really very good. Yeah.
Yes, we have 3 neuroradiologists in our team, and they have a very nice experience. Yeah. They got the ophthalmic artery from the femoral artery in 10 or 15 minutes, and many cases, and good ability to practice the procedure. That's important part of our successful.
Yeah, sure, it's impressive. Yeah.
There is a question, no, not a question, but I would like to know what Dr. Fernando Rojas think about the brachytherapy. I think he has brachytherapy in the Instituto Nacional de Cardiología. I would like to know what is your experience, Dr. Rojas? Dr. Rojas?
But not hearing us.
There anymore. Someone of the audience had more questions. Juan David, you wanted to declare something. You told me.
Yes, I have a comment. From the point of view of the retinal surgeon, I I would like to present the following situation that we often have to solve in our practice, daily practice. For the doctor, Norbert.
Hmm?
Is a 6 years old patient with, without personal history of trauma. He come with us with leukocoria, strabismo, unilateral, quiet eye, no synechias, no cells in anterior chamber, no cataract, blurry vitreous, maybe vitreous hemorrhage or vitreous inflammation. Ultrasound show us vitreous hemorrhage, no calcification, and the computerized tomography is negative for calcification, and MRI is negative for intraocular tumors. It's a very often situation, and sometimes many oncologists or ophthalmologists said us, please make a posterior vitrectomy. What is your opinion about this case? In oldest boys or children, is very often the diffuse retinoblastoma without other findings. What is your opinion about that?
We just recently published a series of cases with an inadvertent vitrectomy in these patients, and that is a mess. And so we were very, very reluctant to do intraocular surgery, in particular vitrectomy in these patients, despite of a recent publication in ophthalmology by a Chinese group, where they advocated vitrectomy to cure patients with retinoblastoma. So that is not our experience. We always would be very, very reluctant to do surgery in these cases. We and others have seen patients dying after surgery, and if they do not die and have a retinoblastoma, at least they are treated extensively with systemic chemotherapy and surgery, so these are real ill children. So I would be reluctant. It's a mess to find out whether this is a retinoblastoma or not. CT is not helpful. A diffuse infiltrating retinoblastoma has no calcification, so the absence of calcification does not exclude a retinoblastoma. And our best diagnostic approach is some techniques in magnetic resonance imaging. Just thinking of what the technique is called. I'm not a radiologist, but there are some techniques to find out diffuse seeding of tumor cells in the eye in advanced retinoblastoma. But you may end up in a situation where you cannot do the final diagnosis. And in those cases where we feel that eye is lost from a functional point of view, we probably would advocate enucleation. Maybe not possible to be sure whether that will be a functional eye or not. But if there's total retina detachment, for example, or anything like that, and we would be sure that the retina function is lost, we probably would advocate enucleation. We have very big respect of just doing inadvertent surgery in retinoblastoma. Our experience are bad, and it's totally different from what has been published in from a Chinese group. Yeah, so I just would follow the patients. MR imaging, it is CISS sequence. That is the technique used to find out whether there's intraocular tumor seeding. It's the best technique in our experience to find out. CT is not helpful. Yeah. Yeah.
Thank you.
It's a real problem.
Another question from the audience for Norbert. Do you have any experience in the treatment of retinoblastoma with gamma knife?
No. We considered that before we had access to protons, but we just don't do it. We wouldn't do that. The gamma knife would have been only an alternative if we wouldn't have protons, but gamma knife has the essential disadvantage that you have a large radiated volume with a small radiation dose due to the conformal construction of the radiation field, but you are radiating parts of the brain and large parts of the skull, and so you end up with a large volume with a relatively small radiation dose, but the volume radiated is large, and in patients with heritable retinoblastoma, it shouldn't be done. So gamma knives is not an option for retinoblastoma.
Okay, that is a question for Maria Elena. How many of the eyes that they preserve the eyes, what kind of vision they preserve later of the treatment?
Yes, that's a very good question. We don't have enough information regarding of the visual acuity. The majority of our patients are very young, and as you know, it's very difficult to take visual acuity or to have visual acuity in these patients. But I think it's very important to make emphasize that if in many patients, even if you see very bad aspect or very long toxicity areas in the fundus, it's very amazing how this patient can behave in good shape in their ordinary life. If you check this patient, they can ride, they can run, they can watch TV or watch computer, but we don't have enough information about visual acuity. But I think to preserve the eye is enough, because the retina in kids is amazing. I don't know if you work with this group of patients, and always we very impressed how is a good vision with a very bad retina or a very bad optic nerve. I would like to know your opinion, Dr. Norfolk, about that.
Yeah, I'm pretty much the same opinion. Just a minute. Pretty much the same opinion as you. We have something amazed on seeing patients have extensive atrophy and still have functional eye. But maybe in some, yeah, now we're doing it for some years, and we have now older children where we could do more precise diagnosis of the function of that eye. But I'm afraid just looking at these eyes that we will end up in some of these eyes with complete atrophy and loss of function. And so we are really puzzled by that. We're seeing so many patients with these atrophic changes, and we are really wondering what we will find in some years when we have the chance to further evaluate the visual function of these eyes, what the function of these eyes will be. Yeah.
Okay. I want to say
it has been, yeah, just one short comment. Unluckily, there are not very much papers dealing with ERGs on these children. And we are just currently doing a series of ERGs in patients with intravitreal and intraarterial chemotherapy. And the only series published so far is done by the New York group. And they found that there's a definite in intravitreal chemotherapy, and probably in intraarterial chemotherapy as well, there's a definite loss in ERG functionality. So it has an effect on ERG. Every cycle of chemotherapy has an effect on the ERG, and probably will have on the function.
Alberto, Dr. Marta Gaviria have more precise information regarding visual acuity. It would be better to hear her.
Okay, good.
Hello, everyone. I would like to share my screen.
Yes.
I don't know how to do it, really.
Down there is an arrow, black arrow in a green box.
Yep. There we are.
Can you see it?
Yep.
Those are the patients where we were able to take visual acuity, and there were only 34 eyes that we were able to take visual acuity, and those were C, D, and E for the international classification retinoblastoma. As you see, 50% of C group had a good visual acuity at the end of the treatment. And 33%, which is 1/3 of C group, had poor vision. And on the other side, D and E group, at the end of the treatment, 1/4 of the cases had a better vision acuity, 20/40, and 72% of the patients had final visual acuity less than 200, poor vision. And here at the end you have the total when you have group, total C, D, and E groups for each visual acuity. We were able to take vision only 24, as I said before, and we excluded the enucleated patients. Is it clear for you? I don't know if you can hear me.
Yes, we can hear
Yes,
you.
we can.
Okay. Was it clear for the person who asked the question?
Okay. Someone has a question for that? And the other thing in between, Dr. Pedro Salazar have some comments about the two presentations. Pedro, go ahead, please.
Thank you, Dr. Leon, and congratulations to Dr. Bornfeld and Maria Elena and her group for the wonderful presentations. Can you hear me? Yes?
Yes, we can hear you.
Yes, Pedro, yes, yes.
Well, my comment is these talks are very useful because they're showing two different approaches for the same disease. And what we're seeing is that nowadays, fortunately, we have a ton of options to choose for our patients. And everyone does what works better for them. And this is very valuable even in developing countries because we can, if we know how to use our limited resources, we can probably get better outcomes, right? For example, in the past 2 years, we've had in my group in Fundonal and Fundación Cardioinfantil, we've had a lot of new patients under 3 months of age, mostly presenting with bilateral cases. This is due because some of the places we work are doing early screening. And in these kids, we have the limitation that we cannot send them for intraarterial because of their size and weight. So we're still working a lot with systemic chemotherapy and helping ourselves with the laser, TTT, and cryo. And we have very good results. So I think that as long as we know what we have as resources and how to use them, we can get excellent outcomes like in other places. And my other comment is that with these kids, we mainly reserve the intraarterial chemo for when they develop recurrences after the 6 cycles of systemic chemo. And it works very well. We've had very good outcomes with the help of the group of Medellin. Thank you very much.
Thank you very much, Pedro. There is another question for the Dr. Bornfeld, for Marta.
Yes, I have a question for Dr. Bornfeld. What's your opinion about intraarterial chemotherapy for bilateral retinoblastoma? I mean, tandem therapy.
Tandem.
Yes.
We have not a very vast experience on that. We haven't done that in just 1 or 2 cases, so it's very limited. Probably it can be done, but we have just done it in about 2 cases, just remember. So our experience is limited. It has been published by the New York group and probably has a place in the armamentarium, in the treatment, but we use it very rarely. Just 2 cases so far.
Yes, because in our protocol, we consider bilateral intraocular chemotherapy in cases of bilateral retinoblastoma.
Yeah,
and we just have one metastasis in just in one patient. I
Okay.
think we need more follow-up to be more precise about this, but I think intraocular chemotherapy, if you compare with systemic chemotherapy, there are some advantages related to the time of recovery, less secondary effects, and I think it could be, in some cases, could be a good option too.
So, definitely it is, but our enthusiasm has been a bit reduced because what we've seen in complications, we have seen severe local complications. We have seen patients in a unilateral case with a compartment syndrome of the leg, which was close to be lost. We have seen vascular occlusion, luckily without infarction, but not a stroke, but occlusion of cerebral vessels. So we have seen a lot of complications, and so we just use it in maybe less as a routine because we have some other options, including protons and it's a radiotherapy, local radiotherapy, and probably use it in more advanced cases. But we are impressed by some of the complications we have seen. Yeah.
Okay, thank you.
Thank you very much. There is any other question from the audience? I think there is no more question. Everything is very good. A very good explanation. Thank you very much, Norbert, for being with us. For us was a very pleasure and honor to have you here. And this is very late or very early for you. I don't know exactly how to say, but thank you very much.
It's very early. It's very early.
It's very early in the morning. That's right. And thank you very much for your excellent presentation, Maria Elena, Marta, and Juan David. Thank you very much for this presentation too. And thank you very much, all the participants. And that was a pleasure for all of us.
Thank you, and have a good night.
Thank you. It was my pleasure.
Have a good night.
Okay.
Thank you very much.
Good night. Goodbye.